Good afternoon and welcome to the Center for Vaccine Preventable Diseases seminar series. My name is Sheza Fadl and I'm assistant professor at the Clinical Public Health Division at Dalla Lana School of Public Health, and I'm a director of operations at the Center for Vaccine Preventable Diseases. Throughout this year's series, we will feature researchers whose works aligns with the center's 4 themes, and those are vaccine hesitancy, value and impact of vaccines, immunization ethics and governance, and immunity and community protection. During today's session, Dr. Anne Burchell will be presenting on vaccination among people living with and at risk for HIV. After Dr. Burchell's presentations, we will have a Q&A session moderated by myself and Dr. Maria Sundaram. So before we start, I first would like to acknowledge that this land on which the University of Toronto operates, for thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting is still home to the many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. Some housekeeping notes. Dr. Burchell's presentation will be followed by Q&A section, and this session is actually being recorded today. Please direct any questions you'd like to be answered in the chat box. If you would like to read your question out loud, that is an option. And just as you post your question in the chat, if you can just say, I would like to post this question out loud. You can direct any questions after the webinar to an email address that will be posted in the chat, cvpd.dlsph@utoronto.ca. Dr. Burchell is a Canada Research Chair in Sexually Transmitted Infection Prevention, an Associate Professor with the Department of Family and Community Medicine and the Dalla Lana School of Public Health, University of Toronto, and a scientist at St. Michael Hospital, Unity Health Toronto. She uses epidemiological data to improve prevention and healthcare services for sexually transmitted infections and minimize the complications of sexually transmitted associated diseases, including HIV, human papillomavirus, syphilis, gonorrhea, and chlamydia. Her research in vaccination to date has predominantly focused on Hpv vaccination among people living with HIV and gay, bisexual, and other men who have sex with men. Most recently, she received an CIHR grant to also study the uptake of and effectiveness of COVID-19 vaccines among people living with HIV. I will introduce the discussants after Dr. Burchell's conversation. And with that note, thank you very much for joining us, Anne, and I'm looking forward to your talk.
Thank you very much, Sheza, for that introduction and also for inviting me to come to speak to this group. I'm looking around at the different names and photos I see in front of me, and I recognize a number of you. So I'm glad that you're here. I'm going to share my slides. Right, Sheza, they're coming in okay? Give me a thumbs up. Great. Okay. So yes, I'm going to be speaking about vaccination among people living with and at risk for HIV. I've been working in research in this population since the mid-90s, actually, when I was a master's student at U of T. So the aims of this talk are kind of to orient you to considerations for what might be the needs for vaccination among people living with HIV and who are at risk of HIV, using 3 examples in particular. So one is going to be human papillomavirus or HPV vaccination among men living with HIV. Then HPV vaccines among gay, bisexual, and other men who have sex with men who are at risk for HIV. And then I'm going to end talking about a new project that's going to be looking at COVID-19 vaccination among people living with HIV. So first, kind of who are we talking about when we're thinking of people living with HIV in Canada? We think there's, VHAC estimates about 62,000 people living with HIV as of the end of 2018. About a third of them are considered immune non-responders. So even though they respond well to antiretroviral treatment, which gets them to undetectable HIV viral load, their CD4 cell counts, which are an important part of the immune system, might not ever quite get up to the normal value. So about a third of them are a little less, are less than 350 cells per millimeter cubed. In addition, people living with HIV tend to face a number of challenges due to social determinants of health issues. Many of them have lower incomes, many are unemployed. And due to their sexual orientation, gender and gender orientations, and racism, they may face a number of additional challenges that put them at risk for various adverse health outcomes. And people continue to be diagnosed with HIV. So in 2019, PHAC reports just over 2,100 people were newly diagnosed with HIV. So this is not an issue that's going away, despite significant advances in treatment and prevention. Just under a third of new diagnoses are among women or females, and just over 2/3 are among men, where for men, the majority have acquired HIV through sexual contact with other men. And it's that population in particular I'm going to be focusing a lot on in this talk. But issues around HPV vaccination and COVID vaccination apply to, of course, all genders living with HIV. So you might be wondering, why would this be a population that we should be thinking about that might have special considerations for vaccination? And generally, there are two reasons why we might need to be thinking about this. The first might be that people living with HIV could be at higher risk for the more severe outcomes caused by a vaccine preventable co-infection. So it may be important to make sure coverage is high in this population. The second issue might be that people have a worse immune response to vaccines when they're living with HIV compared to negative individuals. And this is particularly true if they're people living with HIV that have a low CD4 cell count. There's a number of vaccines where it's been shown that the immune response is suboptimal compared to people living with HIV, not living with HIV. Well, getting back to the first reason, which is they might be at higher risk for more severe outcomes caused by these vaccine preventable co-infections. I'm going to talk a little bit about cancer, in particular anal cancer, in this talk. So we know that some cancers are caused by infections, but in settings like ours, these are actually data from the United States, very similar in terms of the distribution of cancers due to infections. It's really a minority of cancers diagnosed among people that have an infectious cause, 4% attributable fraction in the US in 2008. But for people living with HIV, it's quite different. Nearly half of them of cancers diagnosed in this population are cancers with infectious causes. And one of the most common ones, shown here in yellow, are cancers that are caused by human papillomavirus. So these are American data, but we now actually have some data from Ontario due to a PhD student, Lana, who I know is on this seminar, has been looking at this using data from ICES. And so here you can see that unlike that, only 4% of all cancers diagnosed in the American general population, among people living with HIV in Ontario, about half of new cancers have an infectious cause, shown here in the red colors. And that's even more so among the males, where you can see that about 57% of all cancers diagnosed among men from living with HIV from 1997 to 2008 were caused by an infection. And the top 5 cancers among men living with HIV in that period, anal cancer was the 5th most common cause, most common cancer. Now, anal cancer is actually a very rare cancer. I'm showing here data from France, which was helpful because it was able to contrast between genders and whether or not people had HIV infection. So you can see here that this is true in Canada as well. Really, it's about 1 per 100,000 per year get diagnosed with anal cancer, quite a rare cancer. But when you go to people living with HIV, rates go up quite a bit. So you don't often see this in epidemiology looking at rates, but note the logarithmic scale. So we're really on the vertical axis. So we're going up quite tremendously, so that anyone living with HIV is at considerably higher risk for anal cancer. In particular, the top line in blue is men who have sex with other men have the highest rates of anal cancer. So that it's thought that people living with HIV have a lifetime risk by age 75 of anal cancer of nearly 2%, compared to about 0.1% in the general population. So anal cancer is caused by human papillomavirus. It also causes a number of other cancers. We know it's most infamous for causing cervical cancer, but anal cancer is the next cancer that has the highest attributable fraction. and HPV-16 is consistently the most frequent type in HPV-associated cancers, and that's particularly true for anal cancer. Fortunately, HPV vaccination has been available for use for almost, we're getting there, almost 2 decades, not quite there, but getting there. So this, there are 2 HPV vaccines authorized for use in Canada, Gardasil, the quadrivalent and the nonavalent, that protect against types that are most common in anogenital and oral tract cancers, as well as 2 types, HPV 6 and 11, that aren't cancer causing, but they cause anogenital warts. So they're recommended for use to prevent these outcomes. And they're recommended, most importantly, for youth aged 9 to 13 prior to the onset of sexual activity for a couple of reasons. 1, the immune response is stronger in younger people. And number 2, because HPV is the most common sexually transmitted infection in an unvaccinated population. So pretty much as soon as you become sexually active, it's like the common cold of STIs. So ideally, you immunize prior to the start of people's sexual lives. The vaccines were first developed in women because of its importance for cervical cancer, and later trials came out for males, so that the evidence was stronger to start with school-based programs for girls vaccination, and that's what was done in Canada. And it wasn't until much later that all jurisdictions in Canada introduced gender-neutral programs that included girls and boys in their school-based programs. So it was nearly about a 10-year delay, really, in the introduction of these vaccine programs that are available for males as well. I do want to highlight, this was incredibly exciting findings that came out in the fall of last year, where HPV vaccination has now been around long enough that we have signals of this offering protection against cervical cancer itself. In the early days of the implementation in various jurisdictions, we saw an almost immediate impact on anogenital warts, followed by an impact on precancerous lesions in the cervix. And now there is evidence that there is a significant impact on actually preventing invasive cervical cancer. And it's thought that anal cancer and the involvement in HPV and causing anal cancer is they're quite consistent and analogous. So hopefully we'll have data like this that will come down the line about HPV vaccine preventing anal cancer. Now, despite the fact that we know that they really can work at a population and an individual level, HPV vaccine coverage really isn't great in Ontario. And you can see here showing for 3 vaccines, HPV coverage really is the lowest. It's really hovering around 60%. So this would be getting all the required doses, not just 1 or more. And of course, we all know that the school-based programs for vaccination have been canceled in this school year due to COVID. So we're going to fall even more behind. So in terms of publicly funded HPV vaccination for men or males, we mentioned the school-based program. There's also, starting around 2015, 2016, some provinces introduced targeted programs for high-risk males. So that would include, in some places, this was people living with HIV. In some places, it was men who are gay, bisexual, or otherwise are men who have sex with men. It varies a little bit across jurisdiction. In our province in Ontario, it's specifically for gay, bisexual, and other men who have sex with men and trans-identified individuals up until the age of 26. So in Ontario, if you're living with HIV, that does not in and of itself get you free HPV vaccine. If you are 26 or under and you don't identify as a gay, bisexual, or a man who has sex with men, you're not going to get it through the publicly funded program. And certainly if you're 27 or older, you either have to pay out of pocket, and it's an expensive vaccine, or you have to rely on private insurance to get vaccinated for HPV. It's not in the formulary through Trillium or the Ontario Drug Benefit Program. So what are the clinical guidelines for HPV vaccination among people living with HIV? If we go to the NASTY guidelines on this, there's actually, there was a full report that looked at immunization in immunocompromised populations, including people living with HIV. And they do recommend a 3-dose schedule, in particular because although the vaccine is immunogenic, the immune response can be lower, particularly if a person has lower CD4 cell count or higher viral load. So although there is a keen interest in going to 2-dose, even for adults, for HPV, does not look to be recommended for people living with HIV. Excellent safety and tolerant profiles so there was no safety concern around vaccinating people with HIV, and no concern that the vaccine affected the person's HIV status. There was no deleterious effect on their CD4 cell count or the viral load. So that's good news. Now, for people living with HIV, people caring for them, their physicians, many of them work mostly with clinical guidelines that come out from the States, actually. So what do the American guidelines say for HPV vaccination? They do recommend the 3-dose schedule for and routine vaccination for people living with HIV, but only up until the age of 26. For older ages, the American HIV clinical guidelines say that it's not routinely recommended, and instead recommend shared clinical decision-making regarding HPV vaccination. And part of this issue came out of a particular trial that was published. It was actually stopped for futility. It was first reported at a very well-known HIV conference, CROI, I think it was in 2016, and then later got published, where in a study where they randomized people to receive quadrivalent HPV vaccine to older adults, 27 or older, they did not see strong evidence of vaccine effectiveness against either 6-month persistent anal infection with vaccine preventable types, no benefit against high-grade anal epithelial lesions, some evidence of benefit for persistent oral infection, but depending on how they define this, that benefit went away. So the authors concluded it met the rules for stopping, and they concluded that the results didn't support routine vaccination. And there's really not been another RCT since then. So this is well known in the HIV care arena. So we're left now with only looking at observational studies that will look at, does HPV vaccine, what degree of benefit does it really confer? And we have an actual project where we're going to be looking at this as things go forward. And Catherine Chambers is a PhD student working on that. I know she's on the seminar. So now that's kind of the context of what clinicians might be thinking about when they might be offering and recommending to their male patients living with HIV, should you get vaccinated or not. And we were part of a group led by Daniel Grace that looked at this issue of physician recommendations and did interviews, qualitative work, interviewing physicians who were involved in anal cancer screening, so they're committed to anal cancer prevention, but talk to them about, how do things go with recommending to your patients. And on the plus side, the physicians they spoke with were very much in support of HPV vaccination for all gay and bisexual men, and thought it was a really important part of HIV care. But on the negative side, they acknowledged the cost was a real barrier. A lot of people living with HIV, the average age is about 50 in Ontario. And as I mentioned, for most of them, for many of them, they would not have private insurance to cover this. And then there was a lot of different interpretation of the American guidelines versus the Canadian guidelines, and then how come it wasn't part of the publicly funded programs. So it ended up with what Daniel described as an economic evidentiary conundrum. So many physicians were really stuck. Do I recommend this to my patients or not? And it really resulted in inconsistent recommendations to their patients. So as part of this collaborative effort, this was actually part of a CIHR funded team grant. We also looked at this quantitatively by asking men living with HIV or in an ongoing cohort study, the Ontario HIV Treatment Network cohort study, what their experience had been with the HPV vaccine. So again, these are men who are on average 50 years old. So about 2/3 of them had heard of it. A little under half of them knew that it was recommended for males. Very few had a health professional discuss it with them. and only 7% said they'd actually gotten one or more doses. Really not a lot of uptake of this vaccine. And incidentally, we've more recently done this among women living with HIV, and the proportion who've been vaccinated in the same cohort, and the proportion who've been vaccinated with at least one dose is closer to 13%, a little more, but not much more. Now, in this study among the men, compared to unvaccinated men, the vaccinated men were younger, identified as gay, they had higher education or income, which probably helped them pay for it, a higher number of recent sexual partners, and they were more likely to have a history of STIs, anal-genital warts, or anal cancer. And I just want to mention, we published these findings recently. The lead author is Ramandeep Goel, who's a PhD student here at U of T. So as part of that, we actually asked them about their attitudes as well, at least among the unvaccinated men. We wanted to see how willing they would be to get HPV vaccine if it was offered to them in the next year. And what this graph is showing you is, yes, they would be quite willing to get the HPV vaccine if it's free. Even if they have to co-pay $30 a dose, remember you need 3 doses. About half are willing, and for others, they're starting to think harder. And certainly if they have to pay full price, a minority are willing, and quite frankly would be in a financial position where they could afford to pay that much money for a vaccine. We did ask other questions around using the theory of planned behavior, a number of other statements around potential beliefs around vaccine. And we found that very few men thought the HPV vaccine wouldn't help them. They tended to think it would. There weren't many who said that they didn't need it because they're not at risk. And there weren't issues really about safety. Most trusted vaccine manufacturers provide safe and effective vaccines, and they thought it would be safe to go ahead and get vaccinated. So it wasn't that, anti-vaxxer thinking around HPV vaccines that perhaps in another population we might have seen. Men thought that people who are important to them would encourage them to get the HPV vaccine, and they were very motivated to get the HPV vaccine if their doctor told them it was important for their health. But then you can see in the final bar here, very few agreed that their doctor thinks they could get the HPV vaccine. So we have this disconnect of the doctor recommendation is very important, but it's not really happening. And it certainly wasn't a problem about self-efficacy. Men didn't think it was going to be challenging to get to a doctor to have 3 doses, and they were pretty confident they could figure out how to go about getting it. So I'm going to switch gears a little bit now and talk about HPV vaccination, not only for men living with HIV, but more broadly among gay, bisexual, and other men who have sex with men who some may be living with HIV. The population prevalence here in Toronto is about 20% among gay, bisexual, and other men who have sex with men, but they may not be. Most are not. We do know they're at increased risk for HPV-associated cancers, and a lot of that additional risk is really about the possibility of having HIV co-infection. And I mentioned already that some jurisdictions across Canada have introduced targeted, publicly funded HPV vaccination to these men if they're 26 years of age or younger. So we wanted to know, are these men aware of the HPV vaccine? Are they willing to get it, and have they gotten vaccinated? So these are findings also from Ramandeep Goel, a PhD student at U of T, where she has been describing the HPV vaccination cascade. And here we're looking at data that come from the ENGAGE study, which is a study that recruited gay, bisexual, and other men who have sex with men in Vancouver, Toronto, and Montreal. And I'm showing you here in blue, these are the young guys who were eligible for free HPV vaccine at the time they filled out the questionnaire. And in orange are the men who would not have been eligible at the time of their interview. And they were interviewed on average about a year or 2 after the publicly funded targeted program was implemented. So what you can see here is in blue, a lot more of the guys who were eligible for the HPV vaccine under the publicly funded program had actually gotten at least one dose. Whereas for the older men, a lot more of them were willing to get it. They would intend to get it if it was offered to them, but hadn't actually gotten all the way through to getting at least one dose. We also found, looking at stage 1, are you even aware of the HPV vaccine? More of the older men actually hadn't. And incidentally, in some of the work that Daniel Grace had done in his qualitative work interviewing men, it was sometimes mentioned that 10 years of really the focus being on vaccinating girls had meant that a lot of men, HPV was a women's thing. So they didn't really see themselves as being, as HPV vaccine being something that would benefit them. So what this really seems to suggest is that we want to be focusing on getting vaccine taken up more in this population. It's finding access, increasing awareness and access for the older men would be important. And we can see here that there's still a lot of young men who are in this, intend to get it, but still haven't. In November 2019, when which feels like a utopian time, when we were able to host large in-person meetings, we did this. We had a symposium that we hosted here in Toronto, where we brought people to come together to talk about what were we learning about HPV vaccine uptake among young gay, bisexual, and other men who have sex with men. We had public health professionals come together, researchers, physicians, especially primary care physicians, and people working in service organizations who might be promoting this vaccine, and most importantly, a number of young men themselves who could really talk about their perspectives on what we should be doing next to get vaccine uptake higher than it is. So these findings are, the summary of that symposium is available online. I show the link there. And I wanted to highlight some of the things that came out from some brainstorming sessions we did as part of that day. So we asked folks at this symposium to talk about what information do individuals need to increase uptake. And some of the interesting things that came out here with the young men was, we've been so focused as researchers as talking about the cancer prevention benefit of HPV vaccine. And in fact, in the early days, we really didn't want to mention warts at all, because you were focused on convincing parents to consent to having their children vaccinated. So we really want to talk about how important cancer prevention was. But for these young guys, cancer seems like, something they're going to get decades from now. They really don't feel like at risk of that, but benefit against anogenital warts that happens almost immediately, they definitely didn't want warts. And so this was something that talking about that benefit might actually get a lot more young men's attention. For some of the things around healthcare providers, there really was thinking that not enough healthcare providers even really knew about the publicly funded program, and a lot more could be done to just improve healthcare for young gay, bisexual, and other men who have sex with men in general. And this should really be incorporated within that. We also asked what needs to happen to create opportunities for vaccination. And some of the things that came out there was really creating more ways for young men to self-advocate for it, to find how they could get access to the vaccine, for healthcare providers, ways to update them on guidelines and recommendations. And really another thing that came up was expand the targeted program to all men up until the age of 26, to really reflect the fact that the school-based programs for boys fell behind about a decade, and really making the vaccine only eligible for men who disclose they have sex with other men really would mean a lot of men might not get it that way if they have to self-disclose. Another thing about promoting the experience of vaccination that, again, thinking about how might young men see this as a good thing, really spinning this more as, you have a better sex life if you have HPV vaccines, one less thing to worry about, that might actually be a good way communicate benefits. And the last thing here I wanted to say from the symposium, why should guys care about getting the HPV vaccine and what needs to happen to motivate them? So some of the themes that came out there is really the importance of trust. This is coming out with other issues, right? As we think of vaccine hesitancy for other vaccines, including COVID. But that trust between the service provider and the patient, really building up ways to talk about gay men's health in a way where people feel they're receiving compassionate care without discrimination, and that this really required systematic change. So I'm going to, in the last 10 minutes or so, talk about one other vaccine that is, we're all thinking about this vaccine. It's 24/7 really, COVID-19 vaccination, and what might be the special considerations there for people living with HIV. So PHAC has acknowledged that people who have weakened immune systems, including those living with HIV, might be considered a higher risk population. And why might that be so? Well, I've already mentioned the potential of, it could be that they have a impaired immune response to the vaccine, like we have seen for HPV vaccine. It also could be because risk factors are more common among people living with HIV. So we've certainly seen how race has played out in terms of systemic racism, meaning that many Black and Indigenous people have been more at risk of COVID and severe COVID due to not any innate risk, but simply due to economic circumstance and other circumstances. And that's definitely more common among people living with HIV. So many have people who are of Indigenous or Black ethnicity are overrepresented among people living with HIV. People with HIV are also more likely to be older. Many more are men, and they often have chronic comorbidities. It's also possible that people with HIV might be at lower risk for severe COVID due to the fact that they might, if they're more worried about it, perhaps they're going to adhere more to physical distancing requirements, which could protect them. And there's some thinking as well that the immunosuppression that the HIV virus itself confers might actually partially protect against the immune dysregulation that has characterized severe COVID disease. So it could go either way has been the thinking, and evidence is starting to come in now. In particular, it's a paper that was published quite recently in the Lancet HIV, where they looked at COVID mortality by HIV status in a very large population-based data set. And they did find that there was a higher hazard of COVID-19 death among those living with HIV that couldn't be explained away by adjustment for age and sex, or either for deprivation, ethnicity, smoking, and obesity. And even there looked to be a potential interaction going on, so that this, even if you just restricted to Black people, that the having HIV more than quadrupled your risk of COVID-19 mortality, and still heightened risk for individuals who are non-Black. Now, what's being acknowledged in the HIV research world is that it's still not convincing that really the additional higher risk is due to HIV itself. There's still a lot of thinking that's really could be due to the comorbidities. It could be due to the social determinants of health, and there's some residual confounding going on here. But in general, the thinking is that there is a higher risk for severe COVID. It's just not quite clear as the cause HIV. Certainly among people living with HIV, they're worried. So these are results from a questionnaire from the Ontario HIV Treatment Network cohort study, where we asked people about their beliefs about the risk for COVID. And many of them thought that, in particular, that living with HIV would make it more likely for them to be seriously ill. And a minority, but not as tiny minority, were actually worried about the level of quality of care they would receive. They were worried that they would be stigmatized having HIV and wouldn't receive as good a care as others might, should they end up in hospital. Once the vaccines became authorized for use, we started to ask people about their vaccine uptake, and these are some of the earliest findings. As of March 1st, about 2% of participants in this HIV cohort had said they'd already received their first dose. So we're going to continue to monitor that. These are the most recent stats I have. And nearly 3 in 4 said they would be likely or very likely to get the vaccine if it was available to them today. So although it sounds like 1 in 4 are still hesitant. So what is NACI saying about COVID vaccination for people living with HIV? They are essentially recommending it, that people living with HIV who are considered immunocompetent may go ahead and be vaccinated. There doesn't seem to be any signal that it would be unsafe for them to do so. But they do acknowledge that there isn't evidence yet really to demonstrate whether or not people are going to mount as strong an immune response to the vaccines as people not living with HIV, and is strongly encouraging active surveillance in these participants or recipients of vaccine. There's one article that I was able to find, others in the Sundaram may be familiar with others, but where looking at AstraZeneca in a very small study and comparing immune response to this vaccine between HIV positive and HIV negative individuals, where they found there was no difference in immune response. So that's encouraging. We want there to be no difference. But in that small study, these were healthy people living with HIV. They had viral suppression and a high CD4 cell count. So we need to do more. And I'm happy to report that we now have funding from combined from CIHR, from the COVID Immunity Task Force, we just learned on Friday, and as well through the Canadian HIV Trials Network, to be looking at this very issue of immunogenicity and effectiveness of COVID vaccines among people living with HIV. So it really is going to involve 2 main pieces. One is going to be looking at it's a multi-centered observational cohort study looking at response to the vaccines in people living with HIV, and really targeting recruitment to get those people who might not have been in trials, so that people who are immune non-responders, who are older, who have multimorbidity, and comparing them to negative controls. And then on the other, for the other aim, we're going to be looking at COVID vaccine effectiveness among people living with HIV compared to those who are not, using population-based approaches with health admin data in BC, as well as in Ontario at ICS, and Catherine Chambers is going to be doing some of that work. So to summarize what I've been talking about for nearly 40 minutes here and conclude, for HPV vaccine, there is this economic evidentiary conundrum that's been identified, so that physicians are hesitating to recommend HPV vaccine to older people living with HIV. By older, I mean over the age of 26, because of inconsistencies between guidelines and recommendations. So if physicians don't recommend it, it's a problem because it's a key driver of uptake. Cost is a big problem. It's an expensive vaccine. A lot of people living with HIV can't afford it. We do know that people, young gay bisexual men who are eligible for the publicly funded programs, we estimate that nearly half have had at least 1 dose, but still that means a lot more remain unvaccinated, and that was in large cities. Might not be true in less populated towns and rural environments. The men who got the vaccinated with HPV vaccine tended to be more engaged in sexual health services. Those were and that's likely where they obtained the vaccine. So really suggesting that bundling HPV vaccination with broader sexual health care services could be a way to promote more uptake, as long as it's done compassionately without discrimination, which care for gay, bisexual, and queer men is not always done in a compassionate way. And then finally, that really it's early days for us to know about COVID vaccine effectiveness among people living with and at risk for HIV. So it's going to be an important population to monitor over time. So in closing, I'd like to thank the collaborators involved in the different studies that I've been reporting on today, and in particular, our research staff and trainees. As I mentioned, many of them are attending today, who do phenomenal work on a number of our projects in our program. I will Thank you, and look forward to your questions.
Thank you. Sorry, I think it says you. No, thank you very much. For a great talk. I'm going to just take a moment to introduce our discussant for today. Dr. Maria Sundaram is an infectious disease epidemiologist who has been studying respiratory virus epidemiology and influenza vaccines since 2011. She's published 34 peer-reviewed research articles on topics including influenza, RSV, and HPV, and is currently a weekly expert contributor for BBC World Service on COVID-19. Dr. Sundaram, I'll let you start so that I won't take too much of your precious time. So, thank you.
Thank you so much for that introduction, and thank you, Dr. Burchell, for that really wonderful presentation. It's really, as Shaza mentioned, my main area of expertise is respiratory viruses, and so it's really wonderful to be able to learn so many important lessons from our colleagues who do work in STIs. And I think one of the most important things that I saw come up in your presentation again and again, and I think something that we have not done as good a job of as the STI folks is the importance of trust, and is the importance of qualitative research and investigating the reasons for barriers to vaccines. And when we think about vaccine hesitancy, there are these we have this like Venn diagram of 3 circles where each one circle is confidence, one circle is convenience, and one circle is complacency. And I think that you talked about all 3 of those in your talk. And I'm wondering if you could maybe expand on that a little bit to kind of give us some perspective on how we can identify, each of those 3 separate circles specifically for COVID-19 vaccination. What lessons can we learn from your wonderful work in the STI world?
Thank you for that question. And I would say we certainly haven't solved the problem in HPV vaccines, so I'm learning along with everyone else. But I think that what's really important is to really think at all the different levels that vaccination occurs, and making sure that our research into understanding it is incorporating partnered work with people at those different levels. So coming from the HIV world and sexual health in general, we've had a pretty long history of working with community engagement. In fact, I dare say that we wouldn't be able to do this work at all. Community just wouldn't let us, they wouldn't want to work with us. There's an expectation, and it makes the work just better. It's more rewarding, it's more accurate, and we learn much more about it. So for example, like there are people who have lived experience who are members of our research team. So a lot of good ideas come up from that. So I think that would be a really important lesson. And certainly we've already identified communities for COVID vaccines where they've been harder hit. So we recently hosted, as part of the Canadian HIV Trials Network, a whole session on COVID vaccines among people living with HIV, and really asked for people's perspectives. And there were a number of community members there. And the issue of race and racism came up in that issue for that community as well, that there was some mistrust here around that. So I think it's only through working with communities like that one can really learn what one is up against. And we need their help to think of the solutions.
I thank you so much for that. I couldn't agree with you more about what you were saying specifically about kind of representation, and also this. I think it might even be, and I'm not an expert on this term, but it might even be one step past self-efficacy, where people with sort of longer term complex health conditions find themselves perhaps needing to advocate more often than someone with a kind of a run-of-the-mill average original flavor health system or health immune system, for example. And in many cases, they may need to be an individual expert on their own condition, and then they may even feel as though they're educating their healthcare providers on their particular condition. And so this is something that perhaps not everyone who has a respiratory virus has experienced, although certainly that does exist also in the respiratory epidemiology world. I'm wondering if you have any thoughts on the particular history of community advocacy, specifically with HIV, and this kind of component of individual advocacy of patients living with HIV, and how that might translate to COVID-19 vaccines sort of more broadly.
That's a very complicated question that has a lot of angles to it. And I really do wonder what other people on the call today are thinking around it. So if I understand your question correctly, it's the role of patient self-advocacy. I think that's definitely something that has happened in HIV, where a number of people living with HIV have become expert, and I mean that in the highest possible terms, in learning about HIV and their health, and advocating for their own health, and as well getting involved in research and service organizations to support people living with HIV to advocate for their own community. There's a very strong spirit of advocacy there that I think is coming with COVID as well. It seems to definitely be there that communities want to self-advocate. The other side of that coin, though, is there can be some upset around that kind of thinking is still putting the onus on the individual to solve what is really a systems problem. So while I'm very much for ways to enable and empower community to self-advocate, I think it's really important that we take a hard look at the bigger systems issues. And, I think of the young gay man who might not have fully come out yet to himself, never mind, many have not come out to their provider. There could be ways that we could help him, and some organizations do, to find a healthcare provider and advocate for good care. But one bad experience, right, is that's shut down. So educating physicians and healthcare providers to create open places for people to feel safe, I think is even more important.
Hey, I hope you'll indulge me in another question while folks are maybe thinking of questions to ask or typing. But I wanted to follow up on your point about the structural support as well, sort of not just leaving this as something that individuals have to advocate for themselves. And you were mentioning in your talk a little bit the role of regulatory bodies in sort of, for example, approving or recommending the HPV vaccine. And this is something that's really interesting to me as someone coming from the US. So I just did a postdoc in Emory, and I've spent my entire academic life in the US. So my understanding of vaccine recommendations is largely through ACIP, which is, and I know you know this, but just for anyone else in the call who is not familiar with this term, it's the US version of NACI. So when ACIP makes a recommendation, after the passage of the Affordable Care Act, that recommendation of that vaccine is required to be covered by health insurance, all health insurance providers, and also any health insurance that you might find on the exchange market, so Obamacare. And I'm curious to know if in the case of HPV vaccine, if you think that would have been really helpful in Canada, or if that could have, if that would have had like not an effect, if that makes sense. I think in particular in the US, there was a really big challenge about recommendations, specifically because there was so much public discussion about whether the age should be as young as it currently is. And some people feel as though that may have damaged vaccine hesitancy with parents. But that's not exactly, they're not the only populations that may be of interest we're trying to reach.
You mean for HPV vaccine in particular? Yeah. Which brings up the larger issue of just stigma of sexual behavior in the first place, right? That parents can't imagine that their children are going to grow up to be sexual beings. Of course they are, right? But it can be threatening to parents, unfortunately, which has created a lot of kind of pussyfooting around and how people talk about this vaccine. Don't bring it up, it's about sex. It's a cancer prevention vaccine, which maybe helps in some settings, but I don't think does in this particular population. Now, the other part I think is really, you're talking about pharmacare in a way, I think, and the first part of your question, which is once there's a recommendation for a vaccine, why doesn't it just kind of become, the cost, well, first of all, I will say the cost of this vaccine is too high. Like, it's insane to be over $500 for 3 doses. I understand the drug companies need to make their money back, but it would be really nice to see those prices start to drop. This is also true for HIV medications. They're not universally covered across Canada. So it's a problem in general for HIV, never mind for the vaccines. And I also think there are about 24,000 people in Ontario living in HIV care, diagnosed in HIV care. We're not talking about millions. And I think there's a perception that if we say this, people will go out and say that they have HIV or something to try, because there'll be a stampede for the vaccine and a worry that it's going to break the bank. I don't think that's going to happen, actually. But that's just my personal opinion, that really it's not a huge investment to protect a population that's higher risk.
Certainly an informed opinion, more informed than mine, I'll say. Are there any questions in the chat? No. I have another one, but I don't want to monopolize your time.
I do have a moderator privilege question. If I can actually use my moderator privilege rather to ask a question. But oh goodness, there is somebody beat me to it though. The chat thing. I will ask about. I wanted to come back to school-based immunization, but I think I'll maybe let the person in the question in the chat go first, since. And then maybe I would like to ask you about the school-based immunization and the impact it has, especially with men and vision. So thank you for the wonderful presentation. This is from Edward Ortiz. I was wondering if you could expand into what vaccine will be assessed on the PLHIV COVID-19 vaccine trials and how selection was made.
That's an easy one to answer, because it's not, if you're talking about the study that we just got funding for, that's entirely observational. So it'll be really recruiting people into a study around the time that they're about to be vaccinated with a COVID vaccine, which is the one that they have gotten access to, or there was a decision made just out of practicality that maybe we're going to recruit people after they've been vaccinated and start doing regular blood draws to follow their immune response. So really, it will be left to whatever circumstances, based on age, where they're living, et cetera, what formulation they actually got. And we hope to be able to get the numbers high enough to be able to look at differences there. If not in the study where we're looking at actual immune response, because there'll only be 400 people living with HIV, perhaps in the study that Catherine Chambers will be doing some analysis on, using data from ICS, where we think there's about 23,000 people living with HIV that are in the ICS data holdings, and we'll be able to try and look at is vaccine effectiveness better or worse in this population for different formulations. But as everyone appreciates with COVID, a lot of it is dependent on what data comes in and what the vaccine uptake and distribution patterns are going to be in the coming months.
I think so. And it is a fascinating, and congratulations on the funding for the study. I'm really excited, and particularly as like it also, like when you're going over the NASA recommendations, in the sense of like, oh, this population is not considered immunocompromised too, because it's typically not. Many people will think of it in that regard, like you think it's, oh, they're immunocompromised and therefore there's an expectation that vaccines might not work. So it's really interesting that I'm glad you brought that forward too as well and presented that. I was wondering, since I was just hoping, since oh I'm gonna do that. And though the strategies, I'm gonna use my disco one day. Are there strategies or programs to reduce barriers to young gay, bisexual men, women eligible for vaccination becoming informed that they can receive the vaccine for free?
So that will depend. Really, my sense of, so there have been a number of local programs that have promoted this. So it kind of depends on where you are. So at part of it, at this symposium, we had a number of people come who were involved in different promotional campaigns, including at Toronto Public Health. And then in BC, there was a group called Get Guarded. They did this campaign targeted to gay men that seemed to really help to get the word out. But sometimes these campaigns are done as one-offs, and then there's a backing off. And we're actually having a meeting about this, I think it was in January, and say, is it time to do another campaign? And one of the things that's concerning is if we could do a campaign right now, but are guys going to be able to get into clinics to get these vaccines in the middle of all these, we're on wave 3 right now. We didn't know it was going to be quite so bad in January when we first talked about it, but to drum up interest when people might not be able to have access is a challenge right now. But I think it needs to be an ongoing thing to communicate it, because clearly a lot of young men don't know that they're eligible for this free vaccine.
So I will ask my question this time. And so it was regarding to school-based immunization for HPV. And I think one thing that struck me too is that, just because earlier on you talked about how for the longest time, since it was available for women earlier on, and I feel that school-based programs conditions people that, it's still a lot more acceptable for the adolescent boys and so on, and the conditioning to accepting it. So with this impact of COVID, what would you hope to see if there is a return to school-based immunization, and how might this need to be also put in consideration instead of in the way that it's returned to as well, like in the way that it's because it's something that, to be honest, when I would think about school-based immunization and returning it and actually catching up these additional conditions for certain specialized populations, it was not something on my radar at all, of how one would have to tailor some of the approach in trying to get acceptability back up again.
Yeah, it's going to be a large task to get coverage back up to even where it was, which wasn't great to begin with. And I imagine the focus is going to still be on getting COVID vaccine coverage up as high as we can, even into this fall, going into the next academic year. And in some ways that makes a lot of sense, because although I'm very much a proponent for HPV vaccination, we are talking about an outcome that takes several decades to arrive. So for the cancers anyway, so we do have time, but I hope that there will be investment into the public health infrastructure that needs to happen, not only for these young boys, but for the young girls as well. Like I didn't talk a lot about that in this presentation, but cervical cancer prevention is essential for these young women who otherwise will grow up to be considerably at risk for cervical cancer. So I do hope that there will be an investment into public health infrastructure to get us caught up for all the vaccines that young people should be receiving.
That is 2:00, and I just want to thank you, and then thank you, Maria, for this excellent discussion, and thank you for everybody who's joined. And there's an evaluation link in the chat. I hope you take 2 or 3 minutes just to evaluate the seminar, and also join us for our next seminar on May 31st with Clark Van Der Koller, looking at global vaccine market shaping. So thank you very much, and have a good afternoon, rest of the day. Take care. Thank you so much.
Thank you, Andrea.
Thanks very much. Thanks so much for entertaining all of my very long and rambling questions. I really, really appreciate it.
Not at all. Thank you so much for your comments and thoughts.
All right, take care.